Okay. Thank you all for inviting me. I think this is a very important session because these tests today is mainly investigation based. And these tests are virtually bread and butter for the cardiologists and also for the allied specialists as well. Today, I am going to talk on exercise tolerance test, and I will highlight the basics, and then I will illustrate some practical examples in day-to-day life. We all know that exercise tolerance test, it has got some synonyms like TMT or some other also. Exercise ECG test like this one. Basically, this is a cardiovascular stress test that uses treadmill or bicycle exercise with ECG and blood pressure monitor. So basically, ETT has got two core components. One is exercise and another one is ECG. And the exercise can be done with mainly treadmill, that is most popularly used in Bangladesh, I think elsewhere in the world as well. And another option is using ergometer. And this is commonly bicycle ergometer, but in few cases, arm ergometer can also be used. We have already ECG, and ECG is a very versatile tool for the diagnosis of different types of cardiac ailments, including ischemic heart disease. But why do we need stress tests like ETT? Though ECG is a very cheap and versatile tool, it has got so many limitations. The main limitation is that it has got relatively very low sensitivity, though the specificity is fair for the diagnosis of obstructive coronary artery disease, like a large meta-analysis here. And in that, the sensitivity was only 23% and the specificity of 87% for the diagnosis of obstructive coronary disease. And this was angiographically proven. So we have to have some other tool to diagnose and pick up the coronary artery disease more efficiently. That is where the necessity of some stress tests are needed. If we compare ETT with the other modalities of stress tests and the gold standard invasive coronary angiogram, where does ETT lie? Actually, ETT has got fair sensitivity of 68% and specificity also 77%. If you compare with other tests like stress echo, it was 79% and the 87%. And the nuclear imaging has got to some extent better sensitivity, but the specificity is like that of stress echo. And the gold standard coronary angiogram has got sensitivity of 98%, but look at specificity is 82%. So this is not like 100%. Sometimes we can think that it should have 100% sensitivity and specificity, but the reality is not like so. Among the stress tests, ETT has got some advantages, and current concept is that for the diagnosis of coronary artery disease, among the stress tests, the choice will depend on the indication. So what actually we want? If we are to diagnose coronary artery disease and the resting ECG is interpretable, and it will be interpretable during stress, and the patient can walk up to a certain level satisfactorily, in that case, the stress test of choice is exercise tolerance test. If not, maybe the patient cannot walk, or sometimes the resting ECG may be uninterpretable. In those cases, we have to think of choosing other tests. Also, if our main motto is to see other things like assessment of myocardial viability, In that case, ETT is not a very good stress test. We have to think of other stress tests and the other imaging modalities. Where does ETT perform best? It will perform best with those people with intermediate probability of coronary artery disease. I am telling about for the diagnosis of coronary artery disease. So logically, we should know that what actually intermediate probability of coronary artery disease means. There are some clinical as well as some more objective markers of intermediate probability of coronary artery disease. What are those? The clinical markers of coronary artery disease for which ETT may be a very good test are presence of exertional chest pain or dyspnea. These are indicative of intermediate probability of coronary artery disease in appropriate subjects. But to give it more objective flavor, we have to adopt some other means like Diamond-Forrester score system. This is a very easy to apply clinical tool. Just we have to think of several parameters like age of the patient, sex, and presenting symptoms in the form of whether the patient is having typical angina, atypical angina, or non-anginal chest pain. And if just you look at the chart, you will see that according to the age of the patient, sex, and the presentation, the patient may be placed in very low probability of coronary artery disease and ranging from very low to intermediate and just high, and also very high. So if our patient is in the range of intermediate probability of coronary artery disease, in that case, this ETT will play the optimum role. So it will be the optimum indication for this test for the diagnosis of coronary artery disease. ETT has got very popular keyword. I am telling about workload. What is workload? Workload is measured by METs, metabolic equivalents, and this is nothing but the basal consumption of oxygen that is the body is needed during the resting condition. No added activity is considered. In that case, one MET is equivalent to 3.5 ml oxygen per kg per minute. And in the language of ETT, the energy expenditure and consumption is always expressed in METs. So it is the number or the number of times the energy is being expenditure in comparison to the basal expenditure. And we have also known that for daily living, at least 5 METs of energy is required. We have already known that for ETT, we have to do ECG, and this ECG will be done during stress. And the stress will be applied by means of exercise. There are a number of prescriptions for doing this, and the prescriptions are called protocols. These are the ETT protocols. The protocols are basically of two types. One is, and the most common one is, the graded protocols, and another one is continuous protocol. The continuous protocol is also exemplified by ramp protocol. This is not so commonly used, and I am sure probably this is not at all used in Bangladesh. And among the graded protocols, a number of protocols are available. Among the protocols, Bruce protocol is the most popular one. In few cases, also modified Bruce protocol and Norton protocols are used, and other protocols are mainly of theoretical interest. They are not so used in day-to-day practice. So my talk will be mainly on Bruce protocol. All the protocols have got some common components. What are those? Stage, speed, gradient, and these also differ. And along with the differences in these entities, also the METs produced and just by the protocols are also different during ETT. Now about the most popular one, that is the Bruce protocol. The advantage of Bruce protocol is that this is extensively validated and it has got 7 stages, each lasting 3 minutes. I am talking about the exercise phase, and before the onset of the exercise phase, there are some pre-exercise phase, and the exercise phase is followed by a recovery phase. During the phase, this is also part and parcel of the ETT full test, but during that time, the patient will not perform any sort of exercise. We are seeing that this starts with stage 1 and ultimately it includes up to 7 stages. And along with the change of stages, there will be change of the speed as well as the degree of inclination. What is modified Bruce protocol? This is very like the Bruce protocol, parent protocol, but it is to some extent softer. Before the achievement of the standard stage 1 of the Bruce protocol, in case of modified Bruce protocol, there are 2 warm-up stages. So this is a softer protocol, and the advantage of this protocol is that the debilitated patients, and also whenever we are performing exercise in post-MI patients, this may be a better choice. What are the purposes of ETT? Certainly the most common purpose of doing ETT is diagnosis of coronary artery disease. But another important contribution of ETT is risk stratification and prognostication of coronary artery disease and also the post-MI patients. Another beautiful contribution of ETT is to assessment of functional capacity. It can also give information on evaluation of medical therapy, evaluation of revascularization, and also evaluation of arrhythmias in the form of ppm interrogation, exercise-induced arrhythmia, and also the treatment efficacy for arrhythmia. What are the contraindications of ETT? I am not going about the exhaustive list of contraindications, but there are some absolute contraindications like if the patient is within the 48 hours of acute coronary syndrome, it should not be done. In case of uncontrolled arrhythmias with hemodynamic compromise, symptomatic severe valvular stenosis, decompensated heart failure, active endomyoid pericarditis, acute aortic dissection, acute pulmonary embolism, pulmonary infarction, DVT. And if the patient is having physical debility, and this is so such a degree that it will preclude safe and adequate testing, this test is not suitable for those patients, and this is absolute contraindication for performing ETT. There are some relative contraindications, and in these relative contraindications, if the benefit outweighs the risk, the patient can perform it. What are the complications of ETT? There are some just minor complications, but luckily serious adverse cardiac events are very rare. And this is 1 in 10,000, but certainly this can occur and this should always be kept in mind. How to minimize the risks associated with ETT? There are some basic rules that should be exercised in all aspects of life. Like this should only be done by trained personnel, and the doctor should be present him or herself at the site of ETT, because the responsibility is just on the doctor itself. So I am talking especially for Bangladesh. In Bangladesh, non-doctor trained personnel are not so common. So doctors should themselves be present at the site of ETT. Focused history and physical examination should be taken, and always there should be a search for any systolic murmur in the precordium, and all the available documents, including resting ECG, should be scrutinized. And during the whole procedure of ETT, the clinician and also the associated persons should keep vigilant. Necessary equipments, including the necessary just resuscitative measures, should be well functioning and at hand. What are the parameters that should be observed in the pre-procedural checklist? You should think of current medications. However, there are no uniform consensus regarding withdrawal of beta blocker. But the current opinion favors to some extent that beta blockers can be continued during ETT. You have to demonstrate to the patient what to do, especially at the onset. Be careful, because this is not a common practice, and the patients, especially the females, may, or the elderly people may tend to fall. Ensure good quality electrodes, especially in Bangladesh. Blue sensor may be a very good one, and don't forget to take consent. There are some conditions in which the ECG tracing, that is the changes that occur during exercise in ETT, may not be interpretable. So there are some resting ECGs which in which presents better to avoid ETT. I'm talking about left bundle branch block, like the ECG here, and also the left ventricular hypertrophy with strain. This is an example of WPW syndrome, and also pacing rhythm, dioxin effect, though this is not a very common thing nowadays. It is especially of theoretical interest. One important issue is that we have already known that in presence of left bundle branch block, better to adopt other stress tests for the necessary information. But what about right bundle branch block? Though the authors differ in their opinion, but more are in favor of continuing ETT in presence of complete or incomplete right bundle branch block. This is an example of pre-procedural checklist. What are the parameters that are observed during the main part of the ETT, that is the exercise phase? You have to pay attention to the subjective complaints of the patient, like chest pain, dizziness. You have to think of functional capacity, whether the patient is having chronotropic response in the form of changes in pulse, hemodynamic response, like the changes in blood pressure. But mind it, the measurement of blood pressure during an exercise phase is not a very easy task, and sometimes it is erroneous. The most important component of ETT is just paying meticulous attention to ECG changes. Among the changes, ST segment changes, and also to arrhythmia, bundle branch block, and what is unwanted but certainly present in many situations is artifacts. We have to think of reason for termination of exercise, but this is very important that encourage the patient carefully to perform his or her best, so that the test ultimately yield some practical and better information. These are the per procedural parameters that are commonly observed during the ETT. And when to stop exercise? This is called test endpoint. What are the test endpoints? Commonly, this is based on achievement of the target heart rate. The target heart rate, as we know, commonly is 85% of the maximal heart rate. And the maximal heart rate is calculated by deducting the age from 220 for men and from 210 for women. But achievement of target heart rate is not enough. And nowadays, the favored practice is to perform exercise beyond the achievement of the target heart rate up to the patient's inability to perform any more exercise. This is called symptom limited maximal exercise, and this is now the current recommendation. So don't stop unless indicated, otherwise assessment of functional capacity especially will be jeopardized. We also pay attention to hemodynamic response. What are the hemodynamic responses that can be observed during ETT? The response may be appropriate. That is, during the increment of exercise, the systolic blood pressure will rise and the diastolic blood pressure may either remain unchanged or sometimes it may even decline. But to some extent it can increase. There may be hypotensive blood pressure response. What does it mean? Drop in systolic BP if more than 10 millimeter mercury. What is its significance? It can indicate termination. This is one important criterion to terminate the exercise. Number one. Number two, it may indicate myocardial ischemia leading to left ventricular dysfunction, and it often signifies severe multivessel coronary artery disease. So hypotensive blood pressure response is very important to sense. And another one is hypertensive, that is the exaggerated blood pressure response. What is its definition? This is arbitrarily defined as if the peak systolic blood pressure go beyond 210 millimeter mercury in men and more than 190 millimeter mercury in women, then this is the hypertensive BP response. It predicts risk of hypertension in normotensives. What are the absolute indications for termination of exercise testing? The absolute indication is drop in systolic BP more than 10 millimeter mercury from baseline, especially if it is accompanied by evidence of ischemia. If not accompanied by evidence of ischemia, in that case, drop in blood pressure, systolic blood pressure more than 10 millimeter mercury is a relative indication for termination of exercise. Moderate to severe angina, increasing neurological symptoms in the form of ataxia, dizziness, presyncope, signs of poor perfusion, cyanosis, pallor like these ones, technical difficulties monitoring ECG or the systolic BP. This is another very important practical problem, that sometimes that there may be so much artifact that the tracing can no longer be interpretable. So in that case, better to stop the test. Patient's request to stop, this is a very important absolute indication for termination. But mind it, sometimes the patients are so scared that he or she may request of stopping the test. And if you can think of this, you can encourage carefully to continue further and further. And sometimes you will be astonished that he or she can even perform exercise for 5 minutes, 6 minutes, even 10 minutes. Sustained ventricular tachycardia is an absolute indication for stopping the test. And the ST elevation in leads without Q waves except V1 or AVR are also indications for stopping the test. There are some relative indications. Among the relative indications, the more important is if there is excessive ST depression like more than 2 millimeter or marked QRS axis tip. This is another one important relative indication. Another important relative indication is presence of hypertensive response. This is also very commonly seen during ETT. If the systolic blood pressure goes beyond 250 millimeter mercury or diastolic blood pressure more than 115 millimeter mercury or both, in that case, this constitute a relative indication for stopping the test. However, the most common reason for stopping an exercise test is fatigue and breathlessness as a result of unaccustomed exercise. So this is an Achilles heel for the beautiful test of ETT. How can we report ETT? This is a very practical aspect. There are some minimum requirements that should be included in reporting, like exercise capacity. We can express the exercise capacity fairly in terms of poor, fair, or good. We have to comment on chronotropic response, whether it is normal or there is chronotropic incompetence. That may be partial or complete. Hemodynamic response like normal, hypertensive, or hypotensive. ECG changes, this is the most reliable parameter for diagnosis of coronary artery disease. And there should be a final impression in the form of positive, negative, equivocal, or inconclusive. However, the current preferable terms are whether the test is normal or abnormal. If abnormal, in that case, you can further qualify the nature of abnormality of the test. Now, there is no hard and fast consensus regarding the exercise capacity. However, we can arbitrarily divide it into 3 categories like poor, fair, and good. What is poor? If the exercise, total exercise in the form of METs is less than 6, it may be called poor. It is between 6 and 9 may be fair. And if more than 9 METs, then it is good. Minimum requirements for daily living, as I have already mentioned, 5 METs. And in case of healthy, middle-aged, non-athletic men, 10 METs average may be achieved. And for the moderately active young men, 12 METs maximum can be achieved on an average. And for the distance runners, it may be even 18 to 24 METs that can be achieved. The most important parameter for the ECG changes in ETT is the changes in ST segment. We all know that the most specific ST segment changes for the diagnosis of obstructive coronary artery disease in ETT is downsloping or horizontal ST segment depression. Other types of ST segment depressions are of less practical value and diagnostic value as well. So what are the criteria for positivity of the test? For the positivity or negativity, there are two changes that are considered. One is if there is horizontal or downsloping ST segment depression of 1 millimeter or more in OR or mode leads that persists at 80 milliseconds after the J point. This is the most commonly observed criterion for positivity. And another, though less commonly observed, is presence of horizontal or upsloping ST segment elevation of 1 millimeter or more in leads not having QFs. So this is another criterion less commonly observed for the positivity in ETT. Sometimes one question arises: does ETT have got localization value like the ECG? In general, ETT has got no localization value. By seeing the leads affected, we cannot say that RCA or the LCX or the LED is affected. However, if there is ST segment elevation, this test has got definitely localization value. The leads affected in the form of ST segment elevation may indicate the probable coronary artery involvement. There are some features that are strongly suggestive of positivity, but you cannot say that the test is positive or negative on the basis of these things, like the horizontal or downsloping ST segment depression of less than 1 millimeter, upsloping ST segment depression of more than 2 millimeter, 80 millisecond post-J, presence of exercise-induced hypotension, inverted U waves, frequent multifocal or grouped PVCs, ventricular tachycardia at less than 70% maximal heart rate, increased R wave amplitude, exercise-induced typical angina, third or fourth heart sound or heart murmur. If these features are present, they are strongly suggestive of positivity. So the final report should include the final impression regarding whether the test is positive, negative, equivocal, inconclusive, or uninterpretable. What about the ST segment changes for the definition of positivity and negativity? If we consider ST segment depression or elevation 1 millimeter or more, the sensitivity is around 60% and the specificity is around 90%, so pretty high. But if we consider it 2 millimeter or more, the sensitivity is much more reduced to 20% only. But certainly the specificity goes very high, nearly 98%. So we have to have some balance between the gain and loss. Sometimes during the exercise, there is no much ST segment changes, but the ST segment changes occur during recovery, like the practical scenario present here. You are seeing on the left side that there is exercise test 2, no ST segment depression, but during the recovery at 3 minutes 50 seconds, there are obvious downsloping ST segment depression. So the importance of these types of changes observed in ETT is that it is equally important that it signifies positivity. By this time, we have completed the ETT and what to do with the parameters that have been gained. We can just utilize the parameters we have achieved by this time, like positive, negative, or the METs achieved, functional capacity, or sometimes we can give this a more objective flavor by applying a special tool like the Duke treadmill score. The scoring in the form of Duke treadmill score is that it will indicate whether the patient who has just performed ETT should undergo invasive coronary angiogram or not. I am not going into the details of this. Now, another important term is submaximal ETT. Sometimes the 85% of the maximal predicted heart rate, that is the target heart rate, is not thought to be achieved because of the special situations like post-MI patients or the debilitated patients or the heart failure patients. In those cases, we can set a softer target, like 70% of the maximal predicted heart rate. Or there are some other parameters like up to the achievement of the peak workload of 5 beds. These are called sub-maximal ETT, and these are sometimes planned for special purposes to serve special indications. Now are some practical importance. This is the story of a 46-year-old man with exertional chest pain, and you are seeing the pre-exercise ECG, and this is normal. And when the stage 3 tracing was just illustrated here, look at this. There is obvious horizontal ST segment depression in multiple precordial leads, which is a typical behavior in ETT. So ultimately the patient just complained of severe fatigue, but at stage 3, and he achieved up to 10.2 METs. So the test was reported positive, and on the right side, you are seeing the coronary angiogram of the patient. This was just illustrating important, that is the involvement of the LED. Artifacts are the Achilles heel of ETT. We do not want this, but we cannot avoid this, like the case here. Just you are seeing in the exercise phase stage 2, there are significant amounts of artifacts. And because of the presence of these artifacts, it is very difficult to follow the ECG tracing. But when the patient entered into the recovery stage and it is the tracing taken 1 minute 50 seconds, you are seeing that there are no artifacts. This will occur in your life every time and many times. And what should be done to deal with these types of artifacts? This is a very practical solution that you should take an ECG tracing within 10 to 15 seconds post-exercise. The patient is still on the treadmill, just holding the rails lightly, and you are taking a tracing. This tracing will represent virtually the exercise tracing, but because of the lack of further exercise, there will be no motion artifacts and the tracing will look more healthy. So the changes of during the immediate post-exercise ECG, this may equally indicate what is observed in exercise phase, but certainly without much artifacts. Mind it, 10 to 15 seconds, unlike this one. Another very practical aspect, and I have seen many cardiologists to be fooled by these types of findings. Be aware of computer average rhythms. Just look at this. This is the pre-test tracing. It is normal, but when the patient was performing exercise from stage 1 to stage 2, then stage 3, and this is the tracing in stage 3. Look at this. There are horizontal ST segment depression involving the limb leads as well as especially the limb leads, and also in V1 there is some ST segment elevation. So logically, the reporting physician just reported that the test is positive. But look at this. This is the raw data. In the lower tracing, this is the raw data that has been illustrating the raw data without any computer modification during the exercise. But if we are carefully looking at the raw data, there are much ups and downs and irregularities. I am talking about artifacts. This is probably due to motion artifact. And because of these artifacts, the computer, when performing its just miraculous function of averaging, there are some ST segment depression that are apparent here. But this is due to the average that has been done from this raw data. How can we recognize this? Just this is recognized by the presence of the asterisk marks, that is stars here. The stars here are indicative of computer average rhythms. And the raw data is presented here, though it is very bizarre. One important indication to avoid confusion is you have to think of the presence of the immediate post-exercise tracing. And this is the post-exercise tracing of the patient, though it is taken at 2 minutes. There is no irregularities in the raw data as well as in the computer average rhythms. So by carefully observing this, you can avoid any misinterpretation. Now, sometimes we come across some ETTs with very positivity at very low workload, like this one. This is the case of a 45-year-old man, non-diabetic, non-hypertensive, non-smoker, who presented with exertional dyspnea but no chest pain. So he was having angina equivalent, and the resting ECG was normal, echo also normal. This is the exercise tracing of that patient. And look at this. In the stage 1, there are ST segment depression, horizontal ST segment depression in multiple leads. So the test was positive at low workload, and the changes were also evident in recovery phase. Like this is recovery 1, this is recovery 2, and also note that along with the ST segment depression, there is ST segment elevation in lead AVR. So the test is positive. When coronary angiography was performed, this is the look of the LED, and ultimately the patient was having triple vessel disease, and because of the triple vessel disease, the patient had CABG. Sometimes the ETT is reported as inconclusive, like this one. This is the ETT of a 52-year-old man, and when he performed ETT, this is the resting tracing, normal, and during the stage 1, the patient complained of severe chest pain. But look at the tracing. There was no suggestive ST segment changes in this or any other arrhythmia like this one. So the only complaint of the patient was the presence of chest pain. What to do with this behavior? Is it positive or negative? I have already mentioned that the indicator of positivity or negativity is the presence of ST segment depression or elevation, as there is no ST segment changes. But I am also confused with the presence of severe chest pain of the patient. That may not be cardiac, but whether I am not sure it is due to what. In that case, it is better to comment that the patient is having inconclusive ETT. This is another example. The patient is a elderly man on antihypertensive drugs, on atenolol and amlodipine, and this is the tracing, resting ECG. The patient achieved up to stage 4, but he did not achieve the target heart rate. So the comment was like this one. The patient was having good exercise capacity, normal chronotropic and hemodynamic response. But now I should rather report is that there was partial chronotropic incompetence, probably because of the beta blocker therapy. Target heart rate was not achieved, maybe due to beta blocker. BP was not measured to avoid fall. 80% of maximum predicted heart rate was achieved, 80%, not 85%. He performed 9 minutes of exercise, no significant ST changes occurred during exercise or recovery. This is another example of inconclusive for evidence of exercise-inducible myocardial.
মনোর ভাই,
Yes.
এই আপনার এই আগের স্লাইডটা একটু সরি ইন্টারভিউ করার জন্য শুধু কয়েকটা কোশ্চেন আসলে অ্যারাইজ করেছে আমার মাথায়।
আচ্ছা, হ্যাঁ হ্যাঁ।
সো এখানে আপনি মনে করেন আপনি একটা স্ট্রেস টেস্ট করলেন এবং সেখানে পেশেন্টের আপনার ইকেজি চেঞ্জ নাই অথবা চেস্ট পেন নাই, কিন্তু তার ক্রোনোট্রপিক ইনকম্পিটেন্স আছে অথবা আপনার অন্যান্য হেমোডাইনামিক প্যারামিটারস যেমন আপনার হয়তো ওয়ার্কলোড রিচ করতে পারেনি, হার্ট রেট রিচ করতে পারেনি, how will you proceed from here? এখান থেকে আপনি নেক্সটে কি করবেন? Do you want to do another sort of imaging guided stress test, or do you want to do medical management, or do you want to do a coronary angiogram? How do you usually proceed in scenarios like this?
I have to interpret this in the context of background beta blocker therapy, and I am thinking that the patient's this sort of behavior in ETT is due to beta blocker, but because of the fixed criteria, I cannot declare it to be positive or negative.
Right.
So it is inconclusive. If I am still suspicious of the presence of coronary artery disease, in that case, I have to take the help of other modalities like CT angiography or other things.
Okay.
But if I am assessing the exercise capacity or functional capacity, then I am pretty sure that the patient is having good exercise capacity and he or she can perform heavy driving or like these things.
যেমন আমাদের একটা কোশ্চেন এসেছিল, সেই কোশ্চেনটা ছিল যদি পেশেন্ট বেটা ব্লকারে থাকে, is there any revised target of heart rate or something?
There are some papers regarding this, but no final consensus is present up to this time.
আর আপনার যদি এই স্ট্রেস টেস্টের সময় যে ট্রানজিয়েন্ট যদি কোনো ইসিজি চেঞ্জ হয়, সাপোজ কারো লেফট বান্ডল ব্রাঞ্চ ব্লক ট্রানজিয়েন্টলি দেখা দিল, অথবা হয়তো আপনার lot of multiple PVCs or small non-sustained ventricular tachycardia, সেক্ষেত্রে আপনার ইন্টারপ্রিটেশনটা কিরকম, যে patient should get another form of study or patient should go for an angiogram?
I have some practical examples just in the subsequent slides.
Okay.
Can I continue?
Sure.
Okay. Thank you. Now, this is another example of positive ETT in presence of right bundle branch block. Look at this. This is the pre-test ECG, and the patient is having right bundle branch block, rather complete right bundle branch block. And when ETT was going on, this is stage 1, and then stage 2. This is stage 1, and this is in recovery. In the recovery, just you are seeing that there is horizontal ST segment depression, which was not present in resting ECG, and also ST segment elevation in AVR. In this particular case, in presence of complete right bundle branch block, there are obvious, that is telltale features of positivity of the ETT. Yeah, and the changes are even more apparent, more pronounced during the recovery 2, that is at the end of 6 minutes, recovery 3 rather. Another important example, practical example, this was the story of a 53-year-old man, diabetic, smoker. ETT was being performed at NICVD for screening of coronary artery disease, and the patient complained of chest pain during stage 2. And this is the tracing. Look at this. There are ST segment elevation in multiple leads. So the test was stopped, but the ST segment persisted and even increased in magnitude and persisted in recovery. And when the troponin assay was done, the patient was found troponin positive. So this is an example where there was myocardial infarction during ETT. So these types of catastrophe can occur in 1 in 10,000, mind it. This is an example of equivocal ETT. This is ETT done in 38-year-old gentleman. This is pre-test tracing, and here stage 4, there are some ST segment depression, but mind it, the ST segment depression is mainly upsloping, but probably this is persisting maybe up to 60 milliseconds after the J point. So how to report this? we have to consider performing stage 4 and also these sorts of changes, and the patient has achieved target heart rate. So this is not inconclusive. We can just report this as equivocal.
মনোয়ার ভাই একটু ওই
হ্যাঁ।
মজুমদার স্যার বোধহয় একটু ইয়া হবেন আর কি, রাত হয়ে যাচ্ছে, উনি
ও আচ্ছা, আমি একটু তাড়াতাড়ি করব।
উনি একটু বলুক আর কি, উনি স্যার
আচ্ছা,
বোধহয়
আচ্ছা।
ইয়ে করতে
Sure,
চাচ্ছেন।
sure.
স্যার আপনি একটু আমাদের কিছু বলেন। আমাদের
একটু বলে যাই আমি। আসলে tomorrow there is my flight to Europe, সেজন্য আমি একটুখানি এদিকে ব্যস্ত আছি, কালকে আমাকে ফ্লাই করতে হবে। তো এই দু একটা পয়েন্ট আমি একটু বলে যাই। ডক্টর মনোয়ার তো সবসময় যেভাবে ভালো বলছে, আজকেও এরকম ভালো বলছে and in details. My observation is that in the current scenario in the management and the diagnosis of the chronic coronary syndrome, the exercise tolerance test has been very much downgraded. That is, it is important for rule in of the suspected coronary artery disease, but very little role in the rule out the coronary artery disease. Another thing is the predictive value, which we are used to do. Not only the sensitivity and specificity, also the predictive value, which depends on the extent of the coronary artery disease. When you have got the left main disease or the triple vessel disease, its sensitivity is very high, as well as the specificity is also high. So it depends on the extent of the coronary artery disease. Another, it is not very much discussed, but Dr. Monwarul was once mentioned that the height of the ROF, it is also one of the parameters that can be counted. And previously it was very much counted. Nowadays it is not so much gets important. This one. Another is that the very important is the 6-minute walk test, which should be always to be discussed. 6-minute walk test will not disappear from the clinical practice, because it is an important test for the follow-up and the therapeutic assessment of the pulmonary hypertension for the heart failure patients. And so 6-minute walk test is not that much popular in Bangladesh. I don't know what are the reasons, but it should be popularized to assess the pulmonary arterial hypertension as well as the heart failure patients. With this few things, this is my just observations following the lectures of Dr. Monwarul. Another is the utility of it in the assessment of the arrhythmias. In our student life, when there is a arrhythmia in the ECG strip, our teacher asked us to do some exercise or what is called non-standardized exercise. Ask the patient to just walk and down, and then you see if the arrhythmia disappeared, we are taught that this is non-significant of the arrhythmia. But still now in the exercise test, when the arrhythmias develop or increases, then we can assume that the patient has got the ischemic heart disease. This is also important. And another thing is that when there is what is called that is, you cannot conclude what is will be the interpretation, then I think for the present guideline, we should go to the CT angiogram. And actually the guidelines said first the CT angiogram, and then, but in our country, due to the availability and affordability, the CT angiogram is still to be popular for the diagnostic purposes of the chronic coronary syndrome. With these few words, and with again thanking the organizers, particularly Dr. Mashrafi, as well as Dr. Tasbir also phoned me. And so all these organizers, I express my thanks to inviting me to join this session. And I hope that I could have be there for the longer time, but due to some personal reasons, I have to leave it. Thank you very much, and thank you, the speaker, and I will miss the presentation of Dr. Rabia Khatun. So, thank you.
Thank you, sir. Thank you, sir.
Thank you.
Thank you, sir. That was actually we will take a few more comments. So I'd like to request Professor Wadud sir to make some comments on this lecture.
আমি কি কমেন্ট করবো এখন?
Yes, sir. Yes, sir.
আচ্ছা, একটা কমেন্ট করি যে সবচেয়ে ইম্পর্টেন্ট জিনিসটা বোধহয় মজুমদার স্যার কমেন্ট গুলো করেছেন যে ইটিটির ইম্পর্টেন্সটা কোন দিকে আমরা বেশি দেব। আমি ইটিটি করার ব্যাপারে স্টুডেন্টদের তিনটে জিনিস বলি। এক নম্বরে, তুমি বুঝে নাও তুমি কেন ইটিটি করতে দিচ্ছ। এটা কি তুমি কর্নাইটিস প্রুভ করার জন্য নাকি ফাংশনাল ক্যাপাসিটি দেখার জন্য? এখন একটা রোগীর চেস্ট পেইন আছে, তার দুদিন আগে একটা টিপিক্যাল আনস্টেবল এনজাইনা এপিসোড হয়ে গেছে, তারপরে আমি তাকে ইটিটি করতে দিলাম, এটা আহাম্মকি। তাকে আমি এমআই করার দিকে ঠেলে দিচ্ছি। এবং আমাদের দেশে এরকম একাধিকবার ইনসিডেন্ট ঘটেছে, কারণ হিস্ট্রিটা প্রপারলি নেওয়া হয়নি। 2 নম্বর, একটা রোগী সে বলছে যে আমি দোতলায় উঠলে আমার খারাপ লাগে, ওর ফাংশনাল ক্যাপাসিটি খুব খারাপ, তাকে আমি ইটিটি করতে দিচ্ছি কেন? সে তো করতেই পারবে না ঠিক মতো। আমি ইনকনক্লুসিভ একটা রেজাল্ট নিয়ে পয়সাটা খরচ করার কোনো মানে তো নেই। তাকে আমি আইদার একটা পারফিউশন ইমেজিং করতে দিব অথবা সরাসরি এনজিওগ্রাম করতে বলবো, আমি যদি মনে করি তার প্রি টেস্ট প্রবাবিলিটি অনুযায়ী, রিসপেক্টর অনুযায়ী তার করোনারি ডিসের সম্ভাবনা বেশি। এটা আমার কিন্তু বোঝা উচিত। 2 নম্বর, ইটিটি যখন করতে যাব তখন উদ্দেশ্যটা কি? একটা জিনিস রুল ইন রুল আউট করা ছাড়াও যে আমি যেন নিরাপদে জিনিসটা করে দিতে পারি। বলছে বটে যে বলছে যে 1:1000 মানে 10,000 একটা ক্যাজুয়ালিটি ঘটে। আমার দেশে কি তাই? আমার দেশে কিন্তু তার থেকে একটু বেশি। আমি সেটা খুব বিপজ্জনক ব্যাপার হয়ে যায় মাঝে মধ্যে। মনোয়ার একটু হাসবে, কিন্তু আসলে তো সে একাধিক ঘটনা দেখেছে। আমি ইনসিডেন্সে হিসাব করলে আমাদের দেশে এটা ইনসিডেন্স বেশি। তার মানে আমরা প্রপার অ্যাসেসমেন্ট করতে পারি না। কতগুলো শর্ত আছে, আমি ভালো করে ইসিটা দেখবো, ভালো করে ইকোটা দেখবো, এইটিটা ইন্টারপ্রেট করতে পারবো কিনা সেটা আমি অ্যাসেস করে তারপর তো আমি করবো। আচ্ছা, আরেকটা যেটা আমি প্রবলেম দেখি আমাদের দেশে, আমি এটিটি কতটুকু পর্যন্ত করাবো। একটা রোগী দিব্যি করতে পারছে, আমি তার হার্ট রেট পৌঁছালো, আমি বন্ধ করে দিলাম, লাভটা কি হলো? তাকে ওইটুকু হার্ট রেটে তার ফাংশন মানে হার্ট রেট টার্গেট রিচিভ করলো, কিন্তু আমি তার ফাংশনাল ক্যাপাসিটি কি দেখলাম? সেটা তো দেখা হলো না। ফাংশনাল ক্যাপাসিটি দেখাটা সাংঘাতিক ইম্পর্টেন্ট না? একটা রোগী যদি 30 মিনিটসের উপরে করতে পারে, বলা হয় রোগীর যদি খুব অন্য কোনো কারণ না থাকে তাহলে এনজিওগ্রাম করা উচিতই না। কারণ তাকে করে তুমি সেই মেডিকেল ট্রিটমেন্টই দিতে হবে, তো তুমি সেটাতে এমনিতেই দিতে পারছো, কেন করতে গেলে এনজিওগ্রাম করতে গেলে কেন? কাজে আমি তার ফাংশনাল ক্যাপাসিটি দেখাটা প্রপারলি সেটা খুব ভালো করে আমার এসেসমেন্ট করা উচিত। 2 নম্বর হচ্ছে যে পেশেন্টের যে কোনোদিন অভ্যস্ত না, তাকে ভালো করে এক্সপ্লেনেশন করি নাই, শুরুতেই হার্ট রেট উঠে গেল 120, আমি 3 মিনিটের মধ্যে তার হার্ট রেট উঠে গেল 140, 150, 160 কাছে উঠে যায়, এবং 5 মিনিটের মধ্যে আমি বন্ধ করে দিচ্ছি। সেই রোগীর তাহলে লাভ হলো কি? ইনকনক্লুসিভ একটা রেজাল্ট নিয়ে তাকে আসলে আমি কিছুই না ঘটকা না ঘাটকা কিছুই দিতে পারছি না। এটা কিন্তু আমরা প্রায় দেখি। আরেকটা প্রবলেম দেখি, রোগীর কিন্তু ইটিটি নেগেটিভ, সবই তার নরমাল আছে, অথচ রোগীর বর্ণনা অনুযায়ী টিপিক্যাল তার এনজাইনা হচ্ছে। যখন এরকম হয় তখন আমার জিএম চৌধুরী স্যারের একটা ডায়ালগ মনে পড়ে, বাবা তোমার ক্লিনিক্যাল জাজমেন্ট একদিকে আর রিপোর্ট অন্যদিকে, রিপোর্ট ছুঁড়ে ফেলে দাও। কারণ সেক্ষেত্রে প্রায়ই দেখবো আমরা যে রোগী আসলে ট্রিপল ভেসেল ডিজিজ, খুব ওয়েল কোলাটারালাইজড পেশেন্ট, তার ইটিতে কিছুই চেঞ্জ আসেনি। আমাদের আন্ডারস্ট্যান্ডিং এ থাকা উচিত, মনোয়ার প্রতি এটা বলবে সম্ভবত সামনে, যে কত পার্সেন্ট কেসে সিঙ্গেল ভেসেল ডিজিজে যে আপ টু 40% ক্ষেত্রে কিন্তু ইটিটি নেগেটিভ হতে পারে, 20 to 40। ডাবল ভেসেল পেশেন্টে অ্যারাউন্ড 15% পেশেন্টের ক্ষেত্রে ইটিটি নেগেটিভ হতে পারে, এমনকি ট্রিপল ভেসেল পেশেন্টের 5% ক্ষেত্রে ইটিটি নেগেটিভ হতে পারে। কাজে ইটিটি নেগেটিভ মানেই যে তার একেবারে নেই সেটা আমরা বলতে পারবো না। আমরা বলতে পারবো পার্সেন্টেজ, যে তোমার সম্ভাবনা কম অথবা বেশি। অ্যাবসলিউট কথা বলা কিন্তু ক্ষমতা আমাদের এখানে নেই। দ্যাট উই হ্যাভ টু আন্ডারস্ট্যান্ড। এটা আমাদের যারা জুনিয়ররা করছেন তারা কিন্তু এটা ভালো করে বোঝা উচিত। আমি কেন করব, কি করব, কিভাবে ইন্টারপ্রেট করব, এই 3টা জিনিস আমার থাকলে পরে ইটিটিটাকে আমি খুব চমৎকার ভাবে ব্যবহার করতে পারবো।
Thank you, sir. Monwarul sir, আমরা actually একটু
তো
running short of time.
প্রফেসর
So,
অতুদের কথায় আমার একটা কথা মনে পড়লো আর কি, একটু বলে যাই। এটা হলো বায়াস থিওরেম একটা আছে যে when there is a pretest probability we have to you have to check your post test result with the pretest probability. এটা একটা বায়াস থিওরেম দিয়ে কিন্তু ইন্টারপ্রিটেশনের ETT ইন্টারপ্রিটেশনের একটা সাজেশন আছে, যদিও আমরা ওইটা আর ব্যবহার করি না। ডক্টর মনোয়ার দেখিয়েছে যে প্রি টেস্টের কথাবার্তা বলেছে, কিন্তু বায়াস থিওরেম অ্যাপ্লাই করাটা হয়নি, যেটা হয়তো প্রফেসর যেটা বলতেছিল যে প্রি টেস্ট প্রবাবিলিটি দিয়ে কিন্তু আমাদের রেজাল্ট ইন্টারপ্রিট করা যায়। থ্যাংক ইউ, আমি একটুখানি আমরা সময় নিলাম। থ্যাংক ইউ ভেরি মাচ, সবাইকে ধন্যবাদ, গুড নাইট।
thank you, sir. Monwarul sir, প্রতি একটা question আছে আমাদের learning materials থেকে। Is there any recommendation of hemoglobin level for doing ETT? And last of all, we'll take one question from Dr. Mohammad Mustafa Russell. So, sir, first answer the questions.
This is a very important and practical thing. There is no recommendation regarding the hemoglobin cutoff for ETT or just performing ETT. But certainly, whenever you are interpreting an apparently positive or negative result with an anemic patient, you have to think of that in case of moderate or severe anemia, sometimes ETT may be false positive. There may be ST segment changes because of the relative ischemia in presence of low hemoglobin. So you have to repeat the test after correction of the anemia, or you have to think of adopting other tests.
So we are end of this session. I mean, the first lecture. We take the last question from Dr. Mohammad Mustafa Russell.
Assalamu alaikum. Thank you for giving me the opportunity to ask a question. At first, I would like to express my gratitude to our Honorable Dr. Monwarul Islam, sir. We enjoyed your lecture as we always do. It was a very brilliant lecture. So, sir, my question to you is, what about the medication before doing ETT? In different texts or different sources, there are different opinions regarding beta blocker or anti-anginal medications like nitrates, and also about digoxin. So how can we prepare the patient regarding their medications before doing ETT? This is my first question, and I have another question regarding the use of ETT, exercise tolerance, in case of valvular disease patient. Thank you, sir.
Both the questions are very important. I have given some highlights on the medications, especially the medications that can influence hemodynamics or the coronary status. There may be a chance of interference with these medications. Most important is beta blocker, but also non-dihydropyridine calcium channel blockers and also nitrate. This may interfere with the interpretation, also to some extent digoxin. Regarding beta blocker, some authority just advocate that the drug should be withheld at least 48 hours before doing ETT. But the others are in favor of continuing the drug because there may be chance of just rebound ischemia in case of withdrawal of the beta blocker, and one important aspect. And another one, some also claim that in continuation of beta blocker, there may be rather more regular, smooth evidence of ST segment depression if there is actually ischemia, obstructive coronary disease. And another one regarding
Sir, use of
valvular heart
exercise
disease.
tolerance in
Valvular heart disease. Valvular heart disease. In case of non-severe obstructive valvular heart disease like severe aortic stenosis and hypertrophic obstructive cardiomyopathy with high gradient, this test is contraindicated and this should not be done. But in case of mild to moderate stenotic lesions, this test can be carried out with caution, and sometimes there may be help in making decisions whether that apparent mild or moderate stenotic lesions should be dealt with aggressively or with interventions.
Thank you, sir.
Right. So শুধু এই লাস্টের এই ব্যাপারটাই হচ্ছে যখন যেহেতু আমি ওই ট্যাভারের আগে TAVR সাধারণত indicated for severe symptomatic aortic stenosis, and if there is someone with severe aortic stenosis by echocardiographic criteria, but he doesn't have symptoms, sometimes we send them for exercise to see whether they develop any symptom or there is a drop in blood pressure or not. And if that happens, then we say, yes, this patient needs the management, and then we think about going for either valve replacement or TAVR procedure.
Yes.
Thank you.